Okay, are we ready? Can y'all hear me in the back? Very good. Well, hi, my name is Cliff Courville, and I'm one of the pulmonologists here at the hospital. Work with pulmonary associates on the first floor behind the hospital. And I'm here to talk to you guys today about a little bit about lung cancer as part of our sort of respiratory health campaign. And I'm going to focus primarily on early detection, prevention of lung cancer. We can go into the questions portion about treatment if desired, but the focus of the PowerPoint and the presentations will be primarily on early detection and screening of lung cancer. So just a few of the nuts and bolts on lung cancer.
Could you speak up a little louder?
Yes, ma'am. Yes, ma'am. We certainly can. I'll try. Lung cancer, what is it? It's a cancer that originates in the lungs. So it comes from the lungs. We're not talking about cancer that has spread from another organ to the lungs. 95% of these lung cancers are going to fall into two types, that is small cell carcinoma and non-small cell carcinoma. And of the non-small cell types, adenocarcinoma is going to be the most common. And these will again comprise the vast majority of lung cancers. There are some much more rare types like mesotheliomas, lymphomas, sarcoma type lung cancers, but again, those could be far fewer in number than one of these types you see here. Lung cancer is the second most common cancer diagnosed, not including skin cancers. Breast cancer is the most common, and the next is going to be lung cancer. So it's fairly common. Though it's the second most common, it is the most common cause of cancer death. In other words, it can be a fatal cancer. It accounts for 24% of all cancer-related deaths in the United States. And you see here some pictures. This is just some pictures for you guys to. Pointer may not work, but that you can see some ways cancer may appear on an X-ray. The bottom left film is a picture of a fluid collection on the lung, and the bottom right picture is just a picture of a nodule, just a spot on the lung. And those are kind of some visuals for you to get an idea of what it may look like on an image. This is a schematic, a data review of cancer diagnoses at our hospital here at Memorial Hospital, dating from 2011 to 2015, detailing sort of the trends in cancer diagnosis. The red line at the top is breast cancer, and so that's always, as expected, with it being the most common cancer diagnosed, it's the most common one we've diagnosed here at our hospital. But lung cancer is the blue line just below that, and you can see as of 2015, the frequency of diagnosis of lung cancer had been rising, and as of 2017, lung cancer diagnosis does exceed that of breast cancer diagnosis at our hospital. And so again, it's much more common than you may expect. When we talk about early detection or prevention of lung cancer, it's important to discuss something called a risk factor. A risk factor is anything that increases your odds of developing a disease, such as smoking, increasing your chances of developing heart disease or developing lung cancer or lung disease. You would count smoking as a major risk factor for a variety of diseases. The greatest risk factor for lung cancer is smoking. People ask the question all the time of how did I get this lung cancer, and they'll wonder, is it asbestos or is it radiation exposure or chemicals or pollution. And all of those factors are risk factors, and they may increase your chances of developing lung cancer. There is no risk factor that's going to come close to smoking in terms of its significance. It increases your risk of lung cancer 25 times that of a person who doesn't smoke. And again, smoking as the risk factor is going to account for almost 90% of all the lung cancers that we talk about. There is a slight decline overall in lung cancer diagnosis and incidence, and that decline over the last few years has been through stronger campaigns for smoking cessation. There are other risk factors, and I don't want to ignore those, and it is important to talk about those. Radon is actually the second most common cause of lung cancer or risk factor for lung cancer. Radon is a gas that's emitted from the earth. It's everywhere. It normally is emitted from the earth, out of the rocks and the dirt, and it just dissipates into the atmosphere. You can increase your radon exposure if you live in the ground in an unventilated area. In Louisiana, that doesn't happen very often because we don't have basements. But up north and places in the country that do have basements that perhaps are poorly ventilated, then radon exposure becomes a much greater contributor and it becomes more important. You can check for radon exposure and radon levels in your home. You can contact your local environmental agencies, and they can help you with that. Secondhand smoke is a risk factor as well. Again, it's not going to come close to that of primary smoke exposure, but it is one that we do ask about. And asbestos does increase your lung cancer as well. It's not going to come to the 25 times increase in the odds of developing lung cancer, but it does increase your risk. Asbestos lung cancers, we tend to think specifically about mesothelioma, but it does increase your risk for other types of lung cancers as well. Radiation, and there's a good list of chemicals that can increase your risk for lung cancers. And if you do work around chemicals, if you work at the plants, it's just important to be wary of which chemicals you do work around. Many of those risks of lung cancer are going to be listed on the material safety data sheets associated with those chemicals. So just to, there's my pointer, just to kind of review the lungs and what we're talking about in terms of where cancer can come from. The respiratory tract starts up here in the nose and in the mouth, and it goes down past the vocal cords to your windpipe. We call this your trachea. Your trachea will then divide up into your large bronchial tubes on the left and the right. And these bronchial tubes will then subdivide into smaller airways or bronchioles into air sacs of the lungs. Lung cancers can develop anywhere along this tract, from the upper windpipe down to the lower airways to out here on the edge of the lung. There are lung cancers that can spread to and originate from the lining of the lung. We call the lining of the lung the pleura. And so anywhere basically inside this chest cavity, you could have a lung cancer start, and we would count that as a lung cancer. The stage of the lung cancer is going to depend on how far spread it is. A lung cancer that's in one spot, one lobe that's small, might be a stage 1. If a lung cancer spreads to a different lobe or to the opposite lung, it would be a more advanced stage. In the example of a lung cancer that has spread to the opposite lung, it would be a stage 4 lung cancer. And of course, if a lung cancer has spread outside the chest to the liver, to the bones, it would be a stage 4. So that's a brief overview of the anatomy and how a lung cancer can start in the lung and how it may spread. There are lymph nodes along your windpipe and all along your bronchial tubes. Lung cancer can spread to the lymph nodes, and that would also affect the staging of the lung cancer. When we talk about this staging, it is important to understand how this matters. And basically, the reason why it matters is because lung cancer stage is directly correlated with survival. This is hard to see, so I'll kind of just summarize the high points, but a stage 1A lung cancer at 5 years is a 92% survival. That's this line at the top. These people have stage 1 lung cancer here, and at 5 years, almost everybody's still there. On the other hand, if you have a stage 4 lung cancer here, at 5 years, this line becomes very low to the ground, and at some point, the 5-year survival is 0. And so you can imagine then and interpret from this that you want to be diagnosed with a stage 1 lung cancer if you're going to be diagnosed with lung cancer. Nobody wants to get diagnosed, but if you were to develop lung cancer, you would want to find it here, because early intervention, early treatment would then be associated with a much greater chance of survival. When we're talking about early detection, a good example that everybody tends to understand is breast cancer early detection. This has been something that's been demonstrated for many years to be effective at diagnosing early stage cancer and improving survival. And so therefore we have very robust means to diagnose breast cancer early. Mammograms are widely available. It is well ingrained in the community that we have to get our mammograms, and women know that they need to start doing that at age 40 or age 50. And as a result of the very robust screening program, breast cancer is by far diagnosed at an early stage. This is breast cancer diagnosis at our hospital and in other cancer centers. And as you can tell, at an early stage, almost all breast cancers are found. And as a minority of breast cancers are going to be found at stage 4 because we are so good and at getting our mammograms and being mindful of symptoms and so forth. Unfortunately, lung cancer does not follow the same pattern. Lung cancer at our center and at other centers are more commonly diagnosed at stage 3 or 4. That's going to account for over 65% of all lung cancer diagnoses are already found at an advanced stage. And therefore, the treatment options are going to be much more limited. The survival is going to be much more limited in the far majority of patients that are diagnosed with lung cancer. Given those numbers, the questions we should be asking ourselves is, well, how can we flip that, and how can we reduce death from lung cancer? Well, first and foremost, we have to emphasize smoking as a risk factor for lung cancer. It accounts for 90% of all lung cancers. It would stand to reason that if nobody smoked starting now and going forward, lung cancer would be dramatically reduced in incidence. So therefore, these programs have to be supported, and everybody needs to be made aware of programs available to help people quit smoking. In the state of Louisiana, there are multiple programs one can enter, classes, group therapy, and if you enroll in these programs, this is an example of one, they will give you free counseling sessions, free medications to help you quit smoking. They have one at Moss Memorial, and they have one over at St. Pat's to help people quit smoking. So we have to emphasize this because this is the greatest risk factor. And it is never too late to quit smoking. I want to also kind of hammer on this a little bit more. This was a study that looked at the effect of quitting smoking on survival. If you were to look at the survival of smokers, this is this curve here at the bottom, and the survival of non-smokers, this curve at the top, you would see that the median survival for a never smoker is almost 80. Right? Everybody knows that. The average life expectancy is somewhere around 80 now. But if you smoke, if you're a heavy smoker, you live 10 years less on average. Their average life expectancy for a heavy smoker and current smoker is age 70. If you quit smoking by age 30, this is this curve here, your survival is the same as that of a never smoker. Okay? So if you quit smoking by age 30, it would appear as though nothing is lost. You know, you're right back on top. If you quit smoking by age 40, you gain a few years in your survival, but it's not quite to that top line. If you quit smoking by age 50, your curve is shifted over. You're still below that of a never smoker, but certainly better than a current smoker. And if you quit smoking at age 60, again, you gain 4 years of life back is one way to look at this, but not to that of a never smoker. But I guess I want to just emphasize that you still do gain something. You know, people think I'm smoked all my life. It's age 60. You know, it's too late. But there is still something to gain. This is just survival. This is not including symptoms and other illnesses and burden of disease, because all of those quality of life factors are also improved when someone quits smoking as well. So other than avoiding risk factors, quitting smoking, what else can we do? Well, it is important to be mindful of these other risk factors. If we're exposed to radon, if you live in a poorly ventilated home, it's worthwhile getting those levels checked. If you work in a place with a lot of toxic substances, and you should be wary of those and understand and make sure things are in place to help prevent unnecessary exposure. According to the American Cancer Society, healthy diet is emphasized. Overall, higher fruits and vegetables are associated with better outcomes with cancer and preventing cancer. There is some data suggesting that controlling diabetes more effectively can improve survival from cancer as well. One thought is that cancer cells, they feed off of sugar, and so if someone's sugars are very elevated at all times, then perhaps those cancers may be more aggressive. That's one thought, and so the general recommendation is to control diabetes, have a healthy diet. May also help prevent death from lung cancer. Early detection is the next thing that I want to talk about. They've been trying to find a way or an effective way to screen for lung cancer. Women get mammograms. Everybody gets colonoscopies after age 50. What can be done to screen for lung cancer, to pick it up early? Well, there have been multiple studies that have evaluated doing a chest x-ray every year, maybe checking somebody's sputum, that's what you cough up, your phlegm, to see if there are cancer cells in it to pick it up early. But there have been multiple large trials examining chest x-ray and examining the phlegm somebody coughs up, and those have not been found to be effective. The only effective way of diagnosing lung cancer early is what we call a low-dose CT chest, and that's what I'll talk about next. A CT is a CAT scan. That's what everybody calls a CAT scan. You lay down on the table and you go through the donut, and it gives basically a three-dimensional image of the lung, so you can find smaller nodules, smaller spots more effectively than you can with a chest x-ray. The low-dose portion of the description refers to the dose of radiation associated with the CT scan. In general, CT scans require a lot more radiation to do the image than a chest x-ray, and which has always sort of been a barrier to us doing CT scans on everybody, because too many CT scans can increase your risk for other types of cancers. So by changing the protocol to that of a low dose of radiation, it definitely reduced the risk of that radiation exposure. This low-dose CT screening really became adopted because of this very large study that resulted about 2 years ago. They had done a study looking at chest x-rays annually, which was found to be ineffective. And so then they subsequently began enrolling people into a low-dose CT screening study and compared that to chest x-ray. They enrolled a very large number of patients, over 50,000 patients. They included patients that were considered to be high risk for lung cancer, and they used some statistical analysis to determine who is the highest risk for lung cancer, and the criteria were very specific. They said you had to be between age 55 to 74. You had to have over 30 pack years of smoking. This number refers to the number of packs per day you smoked, and there's 20 cigarettes in a pack, and then how many years you smoked. So 30 pack years, that's you smoked for 15 years, 2 packs per day. You smoked 30 years, 1 pack per day, or you smoked a half a pack per day for 60 years. So that's how this number comes about. If you quit smoking, but you had this number of pack years, you had to have quit within the last 15 years. If you quit smoking 30 years ago, you wouldn't qualify for the study. And this was the result of their study. They compared the low-dose CT arm. So these are the people that underwent an annual screen with a low-dose CT of the chest, and these are the people that underwent an annual chest x-ray, which we know is not effective. The number of lung cancers diagnosed was, of course, much greater in the CT arm. You found more spots. You found more, and more of those spots were going to be lung cancers. The chest x-ray, in general, you'll find lung cancer, but oftentimes it'll be later. But the important thing was that the death from lung cancer was reduced in those patients who underwent the CT screening than those who underwent the chest radiograph. The overall mortality reduction was about 6%. The overall risk reduction from death from lung cancer was 20%. The result of this study and the final analysis you would determine that you need to screen about 300 patients in order to save one life from lung cancer. Okay, that's how you should extrapolate. That's what you should understand from this information. Not everybody who gets screened from CT scan with a CT scan is going to be saved from lung cancer. But overall, if you institute this wide screening protocol, for every 300 patients you screen, you're going to save one life from lung cancer. If you were to compare that to mammograms, you have to screen about 84 women with mammograms in order to save one life from breast cancer. So you have to screen a lot more people with the CT scans in order to have that gain. So that's going to be your larger benefit from screening. You're going to detect lung cancers at an earlier stage, and that was demonstrated in the study. There was a greater number of stage 4 cancers diagnosed in the chest x-ray side of the study, and a greater number of early stage lung cancers diagnosed in the CT side of the study. You diagnose early stage lung cancer that then can be cured with either surgery or definitive radiation. It also should be emphasized that the vast majority of the early stage lung cancers that were diagnosed underwent lobectomies. They underwent major surgery to resect those cancers. And therefore, if you were not able to undergo such a large procedure, a major surgery to remove the cancer, it's unknown if you would really benefit from the screening. To diagnose somebody with a stage 1 lung cancer and then say, we can't do anything about it because your lungs are too bad or because you're too ill, it does not do one any good if you can't do the definitive cure. I'll mention that in a moment again. There was another sort of side effect or benefit of instituting lung cancer screening is that people were more likely to quit smoking. Whether that was because you scared them, because, hey, you told them, hey, you got a spot on your lung now, and they said, oh, I got to quit smoking. Or because they were having continued follow-up and asking about smoking and so forth, maybe they quit smoking for that reason. But the bottom line was that more people were likely to quit smoking if you enrolled them in a program for screening for lung cancer. We have to talk about the side effects of screening. It sounds good at first, but what's the downside? Well, they found a lot of spots on people's lungs when they start doing CT scans. If you were to screen 1 million people with CT scans, you're going to find a spot on 250,000 people. So it's a 24% incidence of finding an abnormality on a scan. Of those spots that you see on the CT scan, of those abnormalities, 96% of those are benign. So there's a lot of what we call false positives. So you're going to undergo a CT scan. There's a very high chance you're going to have something on there, and it's a very high chance the thing that you have on that CT scan is nothing. And these patients who had a false positive, they had to undergo additional testing. Either they had to get another CT scan or they had to undergo biopsies of their lung. So that's important to realize when you're talking about a screening test and whether it's a good test or not. If it's going to find a lot of abnormalities that don't mean anything, well, maybe that's an undue burden on everybody, including the healthcare system, but also the patient as well. There were also incidental findings. These are spots not in the lungs. These are spots, you get a CT of your chest and they find something in the abdomen. They find, you have calcification of your arteries in your heart, or you have gallstones. Well, then all of those abnormalities also need to be addressed too. So you institute CT screening for lung cancer, that can lead to a lot of additional testing, and everybody just needs to be aware of that. There is radiation exposure with each CT scan. Because we're doing the low-dose CT scan, the amount of radiation is equal to about 10 chest x-rays. And somebody has done the math, and they estimate that for every 100 lung cancers you would diagnose, you may cause one cancer just from the radiation exposure. So that's just important to keep in mind. There is a certain level of anxiety with any screening test, just like when someone gets a mammogram or a colonoscopy, they're told they have a lump or they're told they have a polyp. In the same way, when you do a lung scan and you find a nodule, there's a certain amount of stress that comes with that. That's been well documented. It's been found that that stress sort of dissipates over time, once the screening program has been instituted. There is this idea of overdiagnosis of cancers, and basically what this means is that we diagnose a cancer that would not have affected your survival. That could either be because the cancer that is diagnosed is so slow growing. Some cancers take 10, 15 years to grow and ultimately may never spread. And so if you're doing that kind of a screening test on somebody who's, say, 75, and you find a lung cancer that's going to take 15 years to grow, well, if you wouldn't have done anything, they would have made it to 90, maybe before anybody knew that cancer was even there. And so that cancer, what we call an indolent cancer or a slow-growing cancer, may not be relevant to that person's overall health. And then there's another group of people who are ill already. These are people who maybe are already on oxygen, people who have advanced heart disease, people who have conditions that are already going to shorten their life perhaps less than 5 years from now. It may not benefit them to diagnose them with a cancer that, again, may take 5 or 10 years to kill them if they already have a diagnosis that is quite advanced. If you quit smoking more than 15 years ago, it is no longer recommended that you would undergo cancer screening, and so the CT scans would stop at that point. So it is an annual thing. It's an annual assessment to see whether you still benefit from screening. We'll save all questions to the end, so that way everybody will be able to hear them. During a test, what is involved? Well, it's an outpatient imaging study, just like going for a chest x-ray. It may require a cash payment up front. Again, it depends on the radiology clinic. I know St. Pat's was offering low-dose screening CT scans for $75 up front. Memorial's at one point was $200 up front, but it depends on which clinic you're going to. That was also before many of the insurance companies began to cover the low-dose screening CT scans, so that may be different now. It's always changing, but nonetheless, you just need to be aware of that. When you get a screening CT scan, it comes back with a result that may look like this. This is what's called a lung RADS category. It's comparable to the BI-RADS category that you'll see on a mammogram report, and basically the score is a risk assessment. A score of 1, a 2, or a 3 generally just means that you need to have a repeat CT scan at a future interval, either 6 months or a year. A score of 4 means it's a higher risk or a greater suspicion that the finding on the CT scan may represent something, and you'll either do a more frequent CT screen, perhaps in 3 months, or do a PET CT, or do a biopsy, or maybe even surgery to remove the abnormality. And so this is how the score will come back. More often than not, as I mentioned, a finding is going to be there, but it's going to be benign. It's going to require a repeat image in 6 months to a year. So in summary, I wanted to discuss sort of early diagnosis and prevention of lung cancer. It must be emphasized that the single greatest risk factor that we can modify is smoking and eliminating our exposure to tobacco smoke. Or not smoking at all. The low-dose screening CT is the only screening modality for finding lung cancer. It is not recommended for everybody. There is a specific group of people who are going to benefit from screening, and so it requires a discussion with your care provider to see if you fit the bill. You'd say, well, a lot of members of my family had lung cancer. I'm age 60, although I never smoked. There's just really no recommendation for annual screening, annual imaging, as the chances of you having lung cancer are still going to be so low that the risk of screening is potentially going to, it may be too great. I'll now open it up for questions.